very much. Can you hear me? Yeah? Okay, great. Thank you. And I know my topic was supposed to be more clinical overview. I'm going to do that as well. I work at a clinical trial center called National Institutes of Health, where we actually focus very much on congenital muscular dystrophies, and one of the most common conditions we see is Mayerson deficiency, and we also refer to it as LAMA2 related dystrophies. So Mayerson deficiency is the same as LAMA2 related dystrophies. And so I want to kind of talk about the patients in the clinical spectrum as well as preparing for clinical trials, because we do have very promising therapies that are coming. So as you know, MDC1A, or Mayerson deficiency, or LAMA2 related dystrophy, is a congenital onset condition, and actually symptoms really begin during the pregnancy, so prenatally. Many mothers will report that there's some decreased fetal movement during the pregnancy, and at the time of birth there's often symptoms that are evident, and some of those symptoms include low tone, and in the form that's most common, the complete Mayerson deficiency form, independent walking is not typically achieved. Patients with either the complete Mayerson deficiency or partial Mayerson deficiency will pretty much uniformly develop progressive contractures or tightness of the joints, and there also can be progressive involvement of the respiratory muscles causing respiratory insufficiency. There can be a motor neuropathy, so the nerves can be involved. It tends to be quite mild. It's often subclinical, meaning we may not notice it as physicians, but if we test the nerve function, it may be involved. And then the brain has an abnormal appearance of the white matter, and that's just, I'll explain that. That basically is an appearance we see on the magnetic resonance imaging. It doesn't mean that there's a problem per se with the myelin, but it's really a signaling appearance that indicates that there's a difference in the myelin composition. And it's also a very clear sign that helps us with diagnosis. 30% of patients may have seizures, and I'll discuss that a little bit more as well. And over here on the right-hand side, just to kind of give you an idea, in the extracellular matrix outside the muscle is where laminin 211, or Mayerson, is located, and that's kind of just to give you an idea that it's part of the matrix which helps support the muscle. So here are some photographs of patients that have complete Mayerson deficiency, and I include that just to kind of demonstrate there's a pretty classic picture, as I mentioned, with the MRI. By 6 months of age, all patients with complete Mayerson deficiency will have this finding on MRI of the brain, which is really a water content finding of the myelin, or the white matter in the brain. It has this abnormal appearance. Some patients also, if you look very carefully, in the back of the brain, the occipital lobe region, may have a little bit of alteration of the folding of the brain, or the sulci, and that can predispose to seizures, which often start in the back of the brain. So that children will describe at the beginning of a seizure, they see something, whether it be a color or something visual, as kind of what we call an aura before a seizure. And the seizures happen in 30% of patients, and are often what we call complex partial, meaning there's a change in awareness. And they typically can be well controlled with medications, and over time may go away. This is the classic posture we see in patients, particularly with complete Mayerson deficiency, where there's really kind of what we call a lordosis, or a curvature of the lower spine. You can see that evidence of already of some tightness here of the elbows, and here you can see tightness of the knees, so joint contraction of the knees, and here at the Achilles tendons. And also kind of a classic posture of the head and neck. So there's some weakness in neck extension, and there's tendency to sit forward to maintain the head in an upright position. There are other things that are very common in Mayerson deficiency amongst patients, and those are often difficulty in gaining weight and maintaining a good weight, so we try to be very proactive about nutrition. And of course, over time also can be involvement of the respiratory muscles. I wanted to include some photographs that we have taken from our clinic that you can see from a very early age. There's tightness of the joints. So you have joint contractures here of the ankles. You see it here in the feet, and again here in a little older patient. And by this point, you see this knee and ankle tightness. And this is just kind of a demonstration of what we call a pectus, or indentation of the sternum, which can also happen in Mayerson deficiency. In partial Mayerson deficiency, there are a lot of things that are in common with complete Mayerson deficiency, and one of them is there are also typically on brain MRI white matter findings that can be much more mild, so more difficult to find, but still evident. Patients with partial Mayerson deficiency typically achieve walking, but may lose that ability over time. There is also very commonly joint contractures that are very progressive, and there can be a mild motor neuropathy, and again, 30% can have seizures. And here's a video of one of our patients who is ambulatory in early teenage years with partial Mayerson deficiency, to give you an idea. Oops. That's not working. Oh boy. Okay, I'm not sure why that's not working, but so still ambulatory in teenage years, and so the reason why it's important to recognize between the complete Mayerson deficiency and the partial Mayerson deficiency that there are differences but also commonalities, is that we think with some of the therapies that we are developing that perhaps will help children that have the complete Mayerson deficiency have milder symptoms to be more similar to what we see in the partial Mayerson deficiency. We don't know, but we think that may perhaps be the outcome of some of the therapies we're working on. Okay, so I wanted to talk about clinical trial readiness because we are aiming towards getting patients ready for upcoming clinical trials. And one of the most important things with preparing for clinical trials is optimizing clinical care. So making sure that across all centers that we are aiming to get clinical care to a standard of care internationally, which we know can be the best to promote good pulmonary function and stabilize overall medical health going forward. So I just want to start with what we probably think is one of the most important elements for optimizing clinical care and maintaining our patients healthy over time, and that's really respiration or breathing. And included here, just to give a kind of a schematic, when we inhale and exhale, we really rely on the lungs, but also the diaphragm muscle and the intercostal muscles. Now, they're a very important component of breathing for our patients is compliance, or the ability to stretch, really, for the lungs and the chest wall. And what we've seen in our patients with Mayerson deficiency, that it's really this compliance which is decreased. So just as the joints can get tighter over time, so can the chest wall get tighter over time, and that can impact the ability to breathe. And so just kind of an overall just summary is that this is a patient who we had an image who was having an MRI and was breathing during the MRI, in vivo imaging, and you actually can see what's moving downward is the diaphragm. So we have nice movement of the diaphragm. But the chest wall, when we measured the chest wall movement, that was really diminished. So the diaphragm is overactive to compensate for the chest wall. And this helps us to know that we need to maximize chest wall compliance. And how do we do that? Well, one way is we think about being proactive about starting non-invasive ventilation. And the form of non-invasive ventilation we use is called Bipap, or bi-level positive airway pressure. This is the best form of non-invasive ventilation, and not CPAP, which is continual positive airway pressure, which is hard to breathe against. So a continual pressure is hard to exhale against, but a Bipap is a two-pressure approach, and the inspiratory pressure is a higher number. It helps you to inflate the lungs, and when you breathe out against a very low pressure. So I always tell our patients that Bipap is your buddy, so you know that you should use Bipap and not CPAP. And it really is your buddy, because I can tell you that this has maintained our patients stable over time, helped them to thrive, to go on to university, lead full lives, full-time jobs, because they are supporting their respiratory function, which is really the key, I think, for maintaining stability over time. And also to avoid hospitalizations. Another proactive approach, which is very helpful, is using a machine called the cough assist machine, which is the insufflator-exsufflator. And that alternates between positive and negative pressure and can stimulate a cough, which brings up mucus or phlegm. And we recommend that during any respiratory infection that you use this machine as frequently as possible. I call it the miracle worker because it really can help children to recover from a respiratory infection very quickly and to avoid that infection from moving from the head and neck into the lungs, which then becomes pneumonia. So if you use the cough assist proactively, you can bring up that phlegm and really get the airways clear and help our all of our patients stay very stable. And you also can use the cough assist machine on the insufflation mode only as exercise. You could use it every day to expand the chest wall, to expand the lungs. That's probably one of the best ways to help promote pulmonary function. And we've had some data from colleagues in Japan that the use of the cough assist actually helps to stabilize and improve pulmonary function. So we want to be as proactive as possible, because in the past, as a field, we've been more reactive. When children had infections, we thought, oh, we should start BiPAP. Now we know we don't need to wait for warning signs. We should be proactive. And that comes to this next point, which I talk about probably every week with patients, is in the event that there's a surgery planned for scoliosis, for curvature of the spine, BiPAP needs to be established prior to that surgery. If it is, our patients have a very smooth sailing through the surgery and after. And so we recommend that BiPAP be established prior to scoliosis surgery. And again, this may be more common in our complete Mayerson patients, but some of the partial Mayerson deficiency patients also start using BiPAP and may also need scoliosis surgery. We recommend also the cough assist be used daily on the insufflation mode in the weeks prior to surgery to optimize the pulmonary function. And then the key thing is having your neuromuscular team and your lung doctor, your pulmonologist, speak with the anesthesia team and intensive care team to have a plan of care. When we have that in place, things go very smoothly, and the whole team knows what your needs are pre, intra-op, and post-operatively. And this is absolutely essential, because sometimes we need to keep the patient intubated with the tube from the surgery overnight until they're ready for that tube to come out, and then go directly to BiPAP. And if we have that plan in place, things go smoothly. So it's kind of being very proactive and preparing for this period preoperatively and then intraoperatively and postoperatively. And then very importantly, extubation should always occur during the daytime when all the staff are present at bedside. And this is a lesson we've learned, of course, because there have been times when the tube came out in the middle of the night and the teams weren't prepared to help support breathing. And we extubate to BiPAP directly to add support, especially when a child is really not taking deep breaths because of sedation or because of pain. So it's very important. And in the setting of repeat intubation, which can happen sometimes, usually there's successful extubation to BiPAP in the future. This is important because in some hospitals, the intensive care unit will say the child needs a tracheostomy, and that's rarely necessary if you follow this plan. So I think we can avoid any emergencies or the risk of a tracheostomy if we have this plan in place. And it seems to work quite well, thankfully. So another big component of getting ready for clinical trials is studying the natural history of Mayerson deficiency. And so we have some efforts that are already underway, and we're hoping to expand those efforts. One of the efforts underway is that we have collected data from an international group of patients with Mayerson deficiency, looked at their pulmonary function over time, and we looked at it based on ambulatory status and those that are already using non-invasive ventilation to get a sense of if there's a change over time in what we call the forced vital capacity. And this is a number that we collect during pulmonary function testing in the spirometry laboratory when you're asked to breathe out as hard as possible. It's your forced vital capacity, and kind of estimates your pulmonary function and your respiratory muscle strength. As an estimate of that strength, we do see that patients that are ambulatory have a very minimal decline over time in pulmonary function. Those patients that are using a wheelchair and are not yet on BiPAP have a more significant decline. And then the non-ambulatory patients, that are the ones in a wheelchair that are on BiPAP, also have a consistent decline, but a little bit less than those that are not on BiPAP. We also did a few studies at our center looking at kind of an array of motor function measures to figure out how we can measure over time function, so that if we do have a drug that is being tried, we can see that we've changed function. And so we did first what we call a 2-year pilot study. We looked at patients with Mayerson deficiency as well as those with collagen 6 related dystrophies, which is another form of congenital muscular dystrophy. And we tested an array of different measures. One which is a European motor function measure called the MFM32, which is really helpful because we can assess patients who are ambulatory and non-ambulatory. We can assess the same patient over many years, and it has multiple components that are helpful for capturing motor function. We also looked at forced vital capacity, the pulmonary function. We measured muscle strength with what we call myometry. We measured contractures of the joints. patients that were walking, we measured 10-meter walking. We measured a scale, basically a questionnaire scale, and a quality of life scale. And that was done a 2-year period for patients ages 4 to 21 years. We had 15 patients in that study with Mayerson deficiency. In the second year, we added a few more assessments to see what would be the most helpful in capturing motor function. And these are basically all motor function testing modalities, as well as a patient-reported outcome measurement. And it's important to recognize that patient-reported outcomes are more and more recognized by the EMA and the FDA as very viable, important outcomes. So what's important to you as an individual affected with Mayerson deficiency is also important to the regulators, and we need to make sure we're measuring those measurements as well. So what we found from this pilot study was that with the MFM32, that motor function scale that was actually created in France, that there was strong inter-rater reliability, meaning between different physical therapists testing. It was very good scale. There was also strong consistency, and there's also large correlations between this motor scale and other scales, and also pulmonary function. So I think that was helpful for us to recognize the MFM32 is a very helpful motor scale for many of our clinical trials. Another important component of getting ready for clinical trials is figuring out how we measure outcome. How can we measure a change if the drug is being helpful? What do we measure? And just to summarize it, we did a very large study. I'm going to summarize it and make it digestible, I hope. We did a 5 different visits, so over 4 years duration. We followed patients with Mayerson deficiency. We had 24 patients part of the study, and other patients had collagen 6. We had 24 Mayerson patients, and we followed them over 4 years duration prospectively, so each year with the same motor scales, and looking predominantly at the MFM32, and looking for those findings which were significant. So in our Mayerson patients, we found that that MFM32 scale was very helpful in looking at the total score, but as well as what we call the axial, or the muscles that are kind of more close to the head and neck and centrally, that part of the scale was very helpful in following function over time. In testing muscle strength, only certain muscles were very indicative of change over time, and one of them was knee flexion, or bending at the knees. And this is just to show you kind of individual trajectories or individual patterns of patients with the MFM32 to give you an idea that it was a scale that was helpful in measuring over time functional changes. But most importantly is to see that this is kind of an overall correlation, that the MFM32 motor scale correlated very well with other measurements, including pulmonary function. What was a beautiful finding from all this was the quality of life questionnaire in the children did not correlate with motor function, which means that children rated their quality of life higher than you would expect based on their muscle strength, which we actually always see in our Mayerson patients, that they have very strong spirit and they don't rate their quality of life lower because they may be a little bit weak in their muscles. So this was an important kind of study to demonstrate over time that we can measure changes, and how do we measure changes, and to make sure regulators know that we have ability to measure change over time in Mayerson patients, and that these identified motor function outcomes can be used in future clinical trials. I wanted to briefly just summarize, we have had a clinical trial of a medicine in Mayerson deficiency in the past. And just give you a very kind of general overview of what that meant. It was an oral medication. It was called a megapill, and it was tested in Mayerson deficiency patients as well as patients with collagen 6 deficiency. And the reason why it's kind of important to know is that we've proven that we can run a clinical trial in Mayerson deficiency. We can recruit patients and study them over time. And just a quick background is that there was some beautiful data that was done in a mouse model of Mayerson deficiency that demonstrated that this medication actually improved the mice. The mice survived longer. The mouse muscle looked better on this medication. And there was a second mouse model of Mayerson deficiency that also showed benefit with this medication. So it was taken forward to a trial, and in the trial we had 20 patients, and 10 of the patients had Mayerson deficiency. And I would say, without a doubt, it was absolutely amazing how easily we recruited patients, and we didn't have patients that were non-compliant or really dropping out. It was a very smooth trial experience, and it demonstrated that we can run a clinical trial for Mayerson deficiency patients. And just to summarize, the study's aim was to figure out the correct dose of the medication to get the correct blood level, which we were able to determine from this study, and we were able to determine that the drug was safe. So it taught us that we could recruit and run a trial in Mayerson deficiency patients, and that we use a design which was important to evaluate the drug level in the blood of patients. And we used a very careful model to make sure that we were not overshooting our aim for the blood level. We didn't have any side effects that were concerning. We also were able to analyze certain outcome measures during the course of the study. We learned one thing that I think is probably the most important take-home message for the community is that patients coming into the study did not have always the standard of care for their condition. So many patients came to enroll in the study and should have been started on the non-invasive ventilation on the Bipap, and they weren't. And so we started them on the Bipap at the time the study began. But ideally, you want to make sure that your care is optimized to the point where you're getting the best support of your pulmonary function, so that when you enter the study, you're not making a lot of changes, but you're already well supported in a good place. And so we're trying to make sure across the board that we have that standardization of care. We have at this conference, and always a great international consortium among colleagues that we're trying to work on making sure that we've communicated what the standard of care should be to all families and patients and other providers. We learned that monitoring pulmonary function frequently can be difficult to interpret, but it's also important to study. So we learned some lessons on how to run a trial and how to really study pulmonary function. And we also learned this trial had an extensive list of contraindicated medications, which was difficult, but happens sometimes in studies. So just so you know, when you do sign up for a study, sometimes you need to avoid certain medications, or in this case it was actually chocolate as well, while a study's going on. But the patients were uniformly, very wonderful and collaborative and very eager to help. We had a whole team at the NIH we worked with. We had collaborators at Columbia University. We had a data safety monitoring board to make sure that the drug was safe during the study. And we had, the sponsor was Thera Pharmaceuticals. We had a lot of support from Cure CMD, which actually was essential for launching the study in the first place. That's our US-based but international congenital muscular dystrophy family organization, and if you haven't gone onto their website, I recommend you do. So I think everywhere I've worked, and I've worked in the UK and Ireland, I tell patients to go on to the website and to sign up. They have an international registry, which is really important, so that when companies or scientists are looking to launch a clinical trial, we know exactly where the patients are located in the world, and we can better plan for clinical trials. We had some support from the FDA, the Office of Orphan Drug Development, from Endostem, and also the Swiss Myopathy Foundation. So it really took a village to launch this trial, but we learned a lot about running a clinical trial in Mayerson deficiency. And you'll hear later on today about other efforts going forward for other medications and interventions for Mayerson deficiency. So it really is a time where I think we're realistically optimistic we can bring therapies to patients, and we need to be ready for that as a community to plan for those trials. But in the interim, as we're waiting for the next clinical trial to start, I always talk, in my mind, I think about the word cure and the word care as being the same word, just one letter difference. And we want to make sure that until we have the cure ready, that we're giving the best care and we're optimizing your function to the best of its ability. And to speak to that point, there's a patient that I have been corresponding with the family for years who lives in Australia, and they gave me permission to share these images. They've designed a very kind of ingenious approach where there is in the back of the wheelchair some weights, and I have, in case you're interested, all the plans of how this was designed, some weights that help improve upper extremity motor function and movement. And this is important because in Mayerson deficiency, there is weakness of the deltoid muscle, so the ability to lift the arms up can be affected, and that can affect the ability to get the arms on the table. And so with this approach, and again, it's one that's homemade by this family, there's ability to add increasing weights to the back. It's like a pulley system with fishing wire, but it increases the ability to move the arms. And so there are things we can do that can really maximize function and improve ability to move and quality of life, and you can imagine going to school. This helps get the arms on the table. And I think these are things we all should think about as physicians and bioengineers while we're working and preparing for the clinical trials. And I would also underscore that this is the kind of thing where the patient community has tips and pointers and helpful information that we as physicians may not know about as much as the patients. That's why I think going on the Cure CMD group and website and the different they have connections via like the Facebook group. There's a Mayerson deficient, complete Mayerson deficient group and a partial Mayerson deficient group of all ages, families with young children, adults, that really have ability to share their experience, but also pointers such as this where it can be really, very impactful in life. And so I think it's a great place to always connect. And we have patients from around the world that are connecting online or through different patient forums. And this is a picture taken during one of our Cure CMD conferences of 2 Mayerson deficiency patients who met there. These are 2 Mayerson deficiency patients looking after one another and then a young child. So I think our strength lies in each other, I think between families, but also we as a physician community learn so much from all of you. Thank you very much.